Okay, that is fine then. Then welcome to this series of lectures. I'm dealing with the central nervous system.
Doctor, am I permitted to record?
Recording in progress.
So the central nervous system, as you know it, is one area that requires a lot of imaging. For reasons we know, because the central nervous system is contained within the skeleton. We have the brain and the spinal cord, both of them found within the bone skeleton. Not very easy to auscultate. So you need imaging to do that. When we image the central nervous system, especially the brain and the spinal cord, we have to also include the spine and the cranium, because disease of the cranium, disease of the structures around there will also affect the central nervous system. So we are talking about these two systems, the spine, the cranium and the brain. Now, the central nervous system, as we know it, we can say neuroimaging, or if you want, you can call it brain imaging. Basically, those are techniques that you use to directly image the structure, the function, and the pharmacology of the nervous system. Neuroradiologists, we can look at the structure when you're dealing with diseases like tumors or injury, where you have got a lot of huge things within the cranium. But you can also do functional imaging, where you are dealing with metabolic disease or lesions that are really fine. So that one we call functional imaging. For example, if you want to study epilepsy, that would be functional imaging, and you want to identify convulsion, that would be functional imaging. When you're dealing with the tumors, when you're dealing with hemorrhages like the one shown there, that is structure imaging. Now, what are the tools we have for imaging the central nervous system? We have radiography or the X-ray. We have CT. I'm sure you're conversant with this. We have MRI. We have the nuclear imaging, and we have ultrasound, and we have about radiography. We are talking about this. This is an old machine, but we have modern ones which are now digital. And when you do radiography, there are very many views that you can do of the skull, for example. And this is really what you get when you do an X-ray of the cranium or radiograph of the cranium. This is a normal AP lateral view of the cranium, called Towers view. You can also do one like this. This is called a basal view or occipital mental view, or OMV. And this is a view that shows you the pituitary fossa. Just focus there to show you the details of the pituitary. What can we see? What are we able to make a diagnosis of when do radiographs? One of them is fractures. It's very easy to pick fractures like this on a radiograph, especially when they're as big as that. Some of them may be missed on the radiographs. Foreign bodies too, we can be able to see. And we have very many incidents of foreign bodies within the central nervous system, the skull especially. You can have nails and so on. Sometimes you have disease that damages bone, what we call osteolytic lesions, for example, metastases, multiple myeloma, histiocytosis X. In a case like this, you can actually see this is metastasis from the thyroid, and it is destroying bone. You can be able to see multiple myeloma because it damages bone and generates those osteolytic lesions. Histiocytosis X, you can be able to see those lesions. And any other lesion that destroys bone, you may be able to see. Sometimes there are lesions that create bone or form bone, which we call sclerotic lesions. An example is what is shown there. We have a lesion here, which is very dense compared to the rest of the bone. This is called the MNTI. This one is usually found in elderly women. Parostosis frontalis interna. That one can be able to see. You can also be able to see a lesion like this is an osteoma, and any other lesion that forms bone may be shown on a radiograph. We may be able to see things like this. This is a patient who has pneumocephalus. Pneumocephalus is air within the cranium. Cases of accidents. You may be able to see this copper beaten appearance in children, which may suggest that there is increased intracranial pressure. Sometimes this could still be normal. That is what copper beaten appearance means. Or this can also be seen. Patients with sickle cell disease, thalassemia, test to expand their diplo, and you can be able to see this appearance. The here on end appearance is what is shown here. In patients with sickle cell, there's a lot of hematopoiesis. So the advantages of doing craniography, one is that you cover a wide area quickly. For example, you just need a view of the skull that is just one shot. You don't need to do very many. Spatial resolution, when we are saying resolution, we are basically talking about this. You can put a whole film, and also we are able to image patients who are not very cooperative. And this is a modality that is quite available. Almost every hospital has got an X-ray machine. Wherever you're going to work, you'll find it. Safe here is relative because we are using radiation. You need to be careful about radiation. There are disadvantages that we have. One is that we are using radiation, so we need to be careful with that. Resolution, in other words, differentiating one part from the other is really poor. Structures tend to overlap and make diagnosis very difficult, and soft tissues are not resolved in this modality. Now, when you see a patient like this, yes, you have seen this patient has got a dislocation, but we are not able to tell what is happening to the soft tissues. There may be cord compression there, there may be hematoma everywhere, and like what is depicted here. Now that information we missed on that, we're only able to demonstrate what is happening to the bone skeleton. Now what is happening to the bone skeleton is not what is really bothering the patient very much, but what is happening to soft tissues. For example, a patient like this might be having cord. That's one disadvantage. The other modality that we use is CT, and CT has been with us for quite some time. Very many generations of CTs have come. Now we are talking about spiral CT, where or multi-slice CT, where you do many scans at a go. Like this one, actually, this one is 120. Probably they're going to bring others which are many more slices. So when you put a patient here, you scan the patient in a very short time. If it doesn't take you a minute to scan the patient. then you're left generating. A very good modality where you are able to see quite a lot, able to see right inside, you can see bone detail. You are able to make, now this is what you really, and the CT also allows you to do what we call windowing, and you can use a window that depicts bone very well. I'm going to show you images just now. There are windows that depict brain tissue very well or soft tissues very well. So you need to window on your images, the right window, and you're going to see a lot of stuff. So this is a brain window that is shown there. The bone detail here is not very clear. Window, then the bone stands out very clear. CT has got many advantages. One, it is non-invasive. It is available, and I want to believe now that this time every county has got a CT scanner. The others in the private. So you need that. If you have calcification, it's seen better. This one is very difficult to see on plain films. And you are also able to, it is also able to give you good contrast. And contrast here, I mean you are able to differentiate structures one from the other, even without giving contrast. And for this one, you can monitor the patient. Those patients with issues of the cranium sometimes may not be able to follow instructions and they're moving all over. Some of them may require support, and this would be the modality of technical you can use it. And with this modality, what we have, you can put additional software and be able to do 3D reconstruction. You can do CT angio, CTB. And actually, if you're running a radiological unit, this is a very important tool that you must have. '3D reconstruction. So once you have demonstrated your fractures, you can do 3D reconstruction and you can see how you're going to manage that patient. Some disadvantages, though not major ones, you may get artifacts from bone or even foreign bodies if they're there. The scanners we have today have no issues with the posterior fossa but still get very good images. Isodense lesions, when I say isodense brain or neural tissue may be missed, but this is just relative because if you give contrast, sometimes you're able to see these lesions. And because sometimes we give contrast reactions may occur, but I can tell you these are very, very rare, very rare. I want to jump that slide. Now, what are the indications for doing CT? Many. Infections, tumors, and all these are some of the indications that you. Now, this is just to show you a bone window, and you can appreciate that the bone detail here is very, very good. So if you window your CT, the bone window, then you get very good details of your images. And bone, you're not likely to miss any images. This is 3D. This is showing an aorta, which has got coarctation. This is not necessarily neuro, but just to show you that this can be done. You can even color code. And I showed you this earlier. So this is a big advantage for CT now, which you can use. And then we have magnetic resonance imaging. It's very good modality, very good soft tissue differentiation. And you're able to see the soft tissues very well. In this modality, we don't have bone artifact, which is a big plus for MR. If you're doing any anatomical analysis, then this is the modality to look at. I'll show you this image, and this is how it looks like. The bone appears really dark. What you see there is fat within the bone marrow, and that is the brain doing axial, and depending on the strength of your MR, you can see how well you can depict the anatomy of the brain. So that whenever there is a lesion, then there is no the gray matter. You can differentiate that from the white matter. The ventricles, the blood vessels, you can be able to pick all those details. So it's a very good modality. And actually, when you're dealing with the central nervous system, this is a very, very good modality to use. If you compare that to CT, you really want to see those lesions within the brain, probably MR will be the way to go. There are disadvantages of MR. One, you may not be able to visualize fresh blood. Even blood vessels appear as signal voids. It's a morphological technique. These patients, for MR, you take a little bit of time within the machine. And for patients who are uncooperative, it's going to be difficult to image them. And because if you move when you image, then you create artifacts. Patients who have got ferromagnetic implants, like aneurysmal clips, may be contraindicated this machine because a magnetic field. Patients with, say, metallic foreign bodies in the eyes, you may not image because they're going to damage the eye further and so on. It's fairly expensive. An MR was about almost 20,000, sometimes more. Claustrophobia is fear of dark places. If you go to an MR room, it's really dark. Of course, there's a lot of noise. The magnetic field may create metallic points, and therefore, if you are walking into the MR room with anything metallic, you create a projector, and you are warned before there. You don't go in there with any metallic things. And this is what you get when you do MR, very good images. Now, the one thing that MR may have as a mild disadvantage is that you have got to look at very many sequences. Now we talk about T1, we talk about T2, we talk about flare, we talk about diffusion weighting, all those modalities. What the most common modalities used here would be T1, would be T2 sequence. This is a T1 sequence, this is a T2 sequence. And really, this is like a reverse of it. So when you look at CSF, like here on T1, and this is bright, and all the areas where there is fluid is bright. Now, gray matter remains gray here on T1, and white matter remains white. And this one will still remain a bit gray. You see, this one becomes a little gray, the white matter. So you need to get used to these sequences as you look at them. What you see on T1 and what you see on T2. Sometimes we also use contrast in MR. So if you've got a lesion like this, you see there is a tumor there, which is, you can describe this as hypointense on T1, but when you do T2, you see a lesion that is quite bright. And when you give contrast, you see a lesion that is enhancing or picking up contrast, meaning this is a fairly vascular tumor. And that's the kind of information that you get. Another advantage is that when you do MR, you're able to do MR you know the three planes. You don't have to do any reconstructions. You get sagittal images, you get axial images, you get coronal images. Just at once, you don't have to do any reconstruction. The other things that you can do with MR, one of them is Cryptography. And this is Cryptography. And what you do in Cryptography is really looking at the nerves or the tracts within the brain tissue, and you can draw them as shown in that image, and you can study them. Whether they are coming in or they are going out, you can be able to tell by the color codes. And this helps you when you are dealing with tumors, for example, and you want to do surgery, nerve bundles. Then you can be able to look at that and say whether the tumor is really damaging or just displacing. If they are just displaced, you can remove the tumor and the patient's health will be restored. If they damage the nerves and the bundles, then you have something different. You can also do this, what is called MR spectroscopy. I just want to mention this because you'll be hearing about them. And MR spectroscopy is really like doing biochemistry of tumors. So what we're trying to interpret by this MR is interpreting the metabolites that are detected, that can be detected on MR. Metabolites that are produced by tumors or the metabolites that are produced by tissue that is being damaged. And the commonest compounds that we look at are choline, creatinine, lactate. And you can generate a tracing like this and see the concentration of these compounds. And depending on which one is high and low, then you can be able probably to decide where, because if you know the biochemistry, then you know this one is producing this, is most likely this. You can actually reduce your differential diagnosis market. MRI is really MRI, and you want to see what is happening to the brain, especially when there is, especially those patients with, for example, convulsions, and you want to see which areas are active. Many times when you do imaging in those patients, you may find nothing, but usually there is always a place where which triggers off a convulsion. So you can be able to look at that on MR and see which area is active, either during a conversion or during whatever other process, and be able to say, yes, this is the focus for that. And that can be done. Same thing here, you can be able to see that. Can leave that one. Then we have something called angiography. This is really invasive. The technique that we used to use before is quite invasive. But today we know we can do angiography using our CT, we can do angiography using our MR. Now CT and MR gives you really anatomical detail, but there are times when you need to do the invasive technique. The invasive technique, or what you call the transfemoral technique, requires that you put a catheter into the patient's vascular system and advance it all the way up. If you want to look at the vascular system within the brain, you advance your catheters all the way up or wherever you want to the lesion is. And we do this when we have got things like subarachnoid hemorrhage. We have arteriovenous malformations and post-preoperative ablation tumors. Now, where we are doing this is one, we have subarachnoid hemorrhage. Usually, sometimes we have aneurysms where each rupture, and then you can be able to see these ruptures. Sometimes even treat them during that sitting. Arteriovenous malformation, you really want to see which particular blood vessel is supplying the AVM, and therefore, if you are going to do any intervention, then you know which blood vessel to go for. Meningiomas are very vascular tumors. You also need to see the feeding vessels so that you can be pre-planned. This is the angiography suit. It's an old technique of doing angiography, which you no longer do. What we likely to see today is this. This is what is called digital subtraction angiography. And what you are seeing there is just blood vessels. But this patient, and then when we do subtraction, we remove everything else and leave the blood vessels. And we can then study the blood vessels and see which one has got issues. So this is the internal carotid that we are doing, same as this one. So this is an AP view. This is a lateral view, and we can be able to pick the major vessels there. This is the anterior cerebral artery that is there, middle cerebral there, and we see the anterior cerebral there. The posterior circulation, remember most of the blood comes through the vertebral basilar system. You know, the vertebral arteries which come and join to form the basilar artery. And then the terminal branches would be the posterior cerebral arteries. You can see them very, very well. And the other branches that come from the basilar artery, which you can be able to pick. Same thing there. Same thing there. It's like this. This is a patient with a huge aneurysm. This is the internal carotid artery which is being studied. And you see there's an aneurysm. This aneurysm may be causing problems, so you may want to put something there. So you either thrombolyze it or put a stent or put something there. You can do that through this technique. This is CT MR angiography. Or the actually CT this one, showing you the aorta there. You do 3D reconstruction and you're able to work out the blood vessel. This is MR angiography, showing you the vascular system within the brain. And you can see this. This is straightforward. You can see the blood vessels of this internal carotid, another internal carotid. It comes and divides into the anterior. So you can be able to study these vessels and see where the problems. And then we have Sonography. Sonography, we hardly ever use it for adults because the cranium and the spine, you may not be able to penetrate that with ultrasound. But in children, the infant brain, we have open fontanelles which you can use as windows to look. Where we look through the anterior fontanelle, but you can also look at it through the other fontanelle to be able to see the brain. And you can see quite a lot. So you can see lesions which are cystic, or the baby has hydrocephalus. Intracranial hemorrhage can be seen. Sometimes patients with meningitis, though you may not use it to make the diagnosis, you may use it to monitor the progress of treatment and the complications associated. In babies who are not born very well, you can see some of these lesions. It's very easy. And when you do cranial sonography, this is what you see. So this is a sonogram done from the anterior fontanelle. You can see the probe there, and you are seeing the brain. So this is done at the midline. Here you can see that's the corpus callosum there. That is the cavum, septum, pellucidum. You can see third ventricle, fourth ventricle, cerebellum. You can see the rest of the brain tissue. So if there is any lesion there, it is very easy to see. So this is at the midline. Sometimes we do transverse images. This is done and then in the middle cranial fossa. So again, you can see the anatomy there. And then you look at the posterior fossa, you see the coral plexus, you see everything else. A very easy technique, and especially for children, sometimes where you have to do repeated examinations, this may be the study of choice. Again, some more normal images here of the cranium. This is the posterior fossa. Again, there, this is one showing the midline structures. Now, some of the things that you can diagnose with ultrasound are like this particular baby with a dilated lateral ventricle. And you can see this lateral ventricle is dilated. You can measure the diameter, you can follow that up and see the progress. This is another baby with another condition called, there's a monoventricle there. And what is depicted, so you can actually be able to see those cystic structures. We have others here. This is a baby with hydranencephaly. And when you look at this image, you only see the midbrain there. You don't see the cerebral hemisphere. What you are seeing there is just fluid. And this is what you have, just the midbrain there. There is no other brain tissue there. This is, you have got dilated lateral ventricles, dilated third ventricle. This is the temporal horn of the lateral ventricle. And this baby, this particular patient had obstruction of the aqueductal stenosis. And the others, this is a patient with Daddy Walker malformation. You can see the large dilated cyst within the posterior fossa. So it's possible the imaging. Now this machine is in Kenyatta. If you want to see it, you can see it in the nuclear medicine department. And what happens here is that you inject the patient with a radionuclide. Radionuclide is anything that emits some radioactivity. Usually use the gamma rays, and we are able to monitor that with this. This technique is really also biochemical. And what you can produce now today is like this. This kind of image, you're able to produce images like this using that technique, using radionuclides. Same thing here. This is a PET CT showing you activity within the brain. So this patient has been injected with some normal brain. Yeah, I think that is the end. I want to stop there. We have looked at the modalities. Next week, we will look at now some diseases, like you look at trauma, you look at others next week. But those are the modalities we use for looking at the brain, advantages and disadvantages. And thank you very much. I don't know that there are any questions. Are you still there?
Yes, we are. There are no questions in the chat box, Doc.
No questions. Yeah. So we meet next time, we discuss something else. We look at what you see when you have trauma. I think I'm also giving you a lecture next. Is that correct?
Yes.
Yeah, we look at trauma and what we see and things like that. Thank you. Have a good day.
There's only one question.
Yeah,
the difference between T1 and T2 on MRI.
The difference is in terms of the physics, but when you're looking at images, basically, the T1, you look at CSF is going to be dark. If you look at, I think that is what you need to remember. Fat shows different. It's bright in both. Here is dark in both. So those are some of the things, but the physics may be a little difficult because of the physics behind it.
Okay.
Yeah.
Thank you, Doctor.
Recording stopped.